Nick here. I just wanted to go over something that I've really started to learn in greater detail as we're starting to build out our lab. Just going to call this Fun with Triple Trays, Legend of Leo, Lessons from the Lab. So thinking about doing a series of the things that I'm learning myself in the lab as I'm starting to see the other side of the workflow, both in the digital and analog realm. And this would be the first video, and I think this one's going to be insightful. It was for me. So here we have a triple tray. And before I dive into this in any greater detail, I just want to talk about what is a triple tray, why is it called a triple tray. This might be obvious to some, but I think it's just important to reiterate. So triple tray, there's three things being captured. It's the arch with the prep, the opposing arch, and then the bite relation between the two arches. So it's capturing all three of those simultaneously. Obviously, this is a beautiful impression of the prep. The doctor got really good retraction. So as far as the prep goes, 10 out of 10, and the impression of that. The opposing, we'll take a look at that in a second. But one of the things I learned in my residency was one of my instructors had recommended I hold the triple tray up to the light to get a sense of where the patient bit down. And you'll see where the light shines through, this is where the occlusion was. Just from experience and after equilibrating many bites over the years, I know this is not MIP for the patient. So the patient just bit down with all of this material in place, bit down with us putting this big chunk of plastic in there, activating their cheek muscles. So there's all kinds of underlying reasons why the patient may not actually bite into MIP, and they don't know. So we're gonna, at the end of this exercise, we're gonna come up with an algorithm that I find to be best practices for using a triple tray. But coming back here, if I don't see contact on a posterior tooth, I'm automatically thinking that it's not coming together properly. It's not uncommon to have an anterior open bite, but having a posterior open bite on a patient that doesn't have a reason to have a posterior open bite, pretty unlikely. Because of tongue thrust, yes, it's common to have anterior open bites, but really upper or posterior teeth will typically erupt until they come together. And if this one isn't coming together, pretty good sense that this isn't correct. So if I had taken this impression, I probably would have taken a new bite and gone through some sort of exercise to confirm that the patient was biting an MIP, which we'll talk about in a moment. But if we go ahead and flip this over, this was the other side of the triple tray. We can see the patient was maybe not biting into the plastic ridge of the triple tray, but definitely close enough that it might have disturbed the occlusion so that these points here became the highest points. So we can call this a functional lateral shift, probably because the triple tray was a little laterally displaced. So there's several things we can do to avoid this. It's obvious when I say just put it in the center, but I have had hundreds of these over the years. And when I suggest the workflow at the end of this, I'm going to suggest that we practice putting the triple tray in for several reasons, not just to help us know where to kind of center the tray on the arch so that we avoid this problem. But one of the things that I've come to realize, I'm going to come back to this here. The first 20 cases we did were my own cases, and what I'm going to share with you happened with me. So part of the reason why I'm excited to share this is because I feel like I'm a better dentist just from this understanding myself. And then a few other doctors started sending analog impressions in, and I started to realize that this is a pretty common problem. And I started to think to myself, why is it that the doctors that are sending it to us having trouble with occlusion, and I saw the problems in the triple tray, and I 100% quantified that it was a problem in how the patient bit down. How is it that other labs aren't having this problem? And I reached out to a couple friends that live in the lab world, and their comments to me, if I put them all together, here's my conclusion. Labs will, when they see this, re-articulate it by hand, which is not always accurate. It'll be more accurate than this bite was, but hand articulating is not easy to do with a triple tray, in great part because there's no cross arch stabilization of the models. If you don't know what I mean, just separate your triple tray models next time that you're delivering a crown from the lab, and try to stabilize them with 100% confidence that you're in a stable MIP. It's not easy to do. So when labs do that, the dirty little secret is they add a significant amount of space in between the crown that's being made and the opposing arch. So building a crown here, digital design, crown looks beautiful, and they deliver it. Now, the first phase of our journey in the lab, we had a lot of high occlusions, and it was in great part because we were not aware of this significant problem. If I had to quantify with all of the doctors that have sent triple trays, and there's been, upwards of 10 of us, and I consider all of the doctors sending it high-level clinicians. So they're paying attention, but they're still having these issues of high occlusion, and Beak and I have worked this out. But I think sharing this video, we're going to increase the predictability, at least for the cases that we do analog triple tray impressions. Now, these concepts, to a great degree, also hold true for digital impressions. So this is not only for analog, but I think analog has a higher degree of this potential error in the workflow. So coming back to what labs do. So labs will say, if we undershoot by 25%, in other words, we leave 25, 30, 50, 70 microns of space between the crown and the opposing arch, they might have 5% remakes. And you can imagine if a lab has to do remakes, that's rather catastrophic to their bottom line. So they're better off undershooting than trying to get it perfect and having 50% of them needing adjustments or coming back for redos. So the conversations I have with lab techs is, labs just undershoot it, and they love hearing from their dentist how perfect the occlusion is every time. Well, how do we know the occlusion's perfect if it's not high and we have to adjust it? Well, if you have the patient tap, tap, tap with articulating paper and you see a spot, that's probably a perfect occlusion. And I'll be honest, I don't think I've had any lab I've ever worked with where I get those every single time. So let's agree to the understanding that just because the patient doesn't feel a high spot when we deliver a crown doesn't mean it's perfect. So if we don't have a blue dot or a red dot, which with polished zirconia, or let's say polished zirconia, with glazed zirconia, marks are pretty hard to produce. So we don't necessarily know whether we're actually in occlusion or a little short. And that's where shim stock comes in. So for those of you who have never used shim stock, this is a great opportunity to start learning how to use it. It's used for all kinds of different things, but one of the things I use it for is to quantify down to the 10 micron scale how much space there is between occluding entities. So an upper crown, lower crown up against its opposing tooth. So let's say when we deliver this crown, we have the patient tap, tap, tap. Oh, it feels great, doc. You check the margins, everything looks good. And you're like, man, my lab is amazing. You go ahead and cement it, patient's on their way, and you never know any difference. So you call that clinical success. But you're relying on super eruption of the tooth. And I'd want to quantify that. Just so as I work with my lab, I can say, look, every one of your crowns has been 50 microns short. Dial that into your equation. The next time you're designing a crown, I would rather have one be slightly high, that I adjust a little bit, that would be perfect for me, than to be short. Shim stock will allow us to do that. So what you do is you put the shim stock in between the crown and the opposing tooth, and you see if it binds. If it binds, then that tells you your gap or contact is less than 10 microns of a space. But if you pull it through and it's passive, then you know it's more than 10. So then you put 2 together, 3 together, 4 together, until you get, I wouldn't say passive binding, but binding where you have to pull pretty hard. And I think most of us know what this means. You count the number of shim stocks, and that tells you how many tens of microns the gap was. And if your gap's up in the 50, 60, 70, up to 100, sometimes even more, your lab's not producing great results. It just feels that way because you don't have to pull out the articulating paper, tap, 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 adjust, do that for 10 minutes, which is obviously very frustrating. So in our journey towards perfection, I think we're going to have to quantify that potential gap. Now, where this becomes relevant is if the triple tray bite is off, the lab's going to have to make decisions. And if you start to notice that gap is pretty high, the lab might say, well, every time you send an impression, the bite's off. So why don't we learn how to take a good bite? And that's the whole point of this here. Good bite with a triple tray. So this case here, this is what a video that Vika sent me.
What do you think of this bite? This is going with the impressions, so the premolars are the only ones touching and see-through in the impression. I'm pretty sure the molars are supposed to touch, but...
So Vika's developed the eye to understand what's normal, what's not normal, so she has certain triggers. When she sees things, she sends me videos and pictures, and we figure out what to do. This was one of those cases, so I applaud Vika on seeing this. The doctor did a beautiful prep, so no knock to the doctor here. This again happened to me, so not the pot calling the kettle black, but really just trying to identify how we can be better. So without a question, and Vika actually uses articulating paper to reproduce it, and then she matches it to the show through on the triple tray. And this mounting was exactly like the articulating marks on the mounting were exactly where the show throughs were when she held up the triple tray to the light, which means she did a good job mounting the hinge. So there's no, she mounted it exactly as the triple tray captured the bite. And we just don't think this is accurate. So what I asked her to do was to unhinge this and re-articulate it by hand, which is not easy to do with triple trays. There's not a whole lot of information here to use, but focusing on trying to bring these back teeth together. And let's take a look at that video.
What do you think of that? And this is another version. This is when I completely don't use the articulators in the back. So the molars are touching, the premolars are touching, but then the front is open, which I don't think is right either.
So one of the clues that I have here to know this is right, the angle of this upper molar, that angle is actually commonly the angle of the eminentia of the jaw joint. So the only way you're going to get posterior wear like this is if these two teeth are coming together and there's actually a distalizing force. So we know that this patient is not in centric relation. They're trying to go to centric relation, topic for another day. But this tells me with a high degree of confidence that this is a more accurate bite. This looks better here. The gap between the prep and the upper tooth still looks pretty accurate. And, I kind of wish I knew what the patient had for anterior occlusion, but I'm just going to make the assumption based upon the accuracy of this that the front teeth don't come together. It'd be nice if these came together and these came together and there was space here for the prep. So the lab's having to make a lot of decisions here. And, this is a standard triple tray sent to labs like Glidewell and the other big labs across the country. They're seeing these things on the other side. They just don't spend time trying to educate dentists on this stuff because it's a waste of their time. I wouldn't say it's a waste of their time. It's not efficient for them and it doesn't improve their bottom line, so they just make decisions to try to get it to the finish line without the doctors complaining. So let's take a look here. Back to the other side of the triple tray. I think the take-home message is this triple tray, had it been centered, probably would have been better. But there is a workflow or an algorithm I want to put together. And if you guys have any suggestions on things I can add to this, I'd love to hear it. The first thing we do is dry runs. So one of the best things I've ever learned in clinical dentistry is doing dry runs. So when I do full arch impressions for full mouth rehabs, just going through a dry run of the impression with the assistant or assistants going over who's going to do what when, and you actually orchestrate it and do it without the PVS material, it's one of the best things you can do. And I think when it comes to triple trays, one of the best things you can do is have the patient bite into MIP first and observe the relationship between the front teeth. You can look in the back too, but you're not going to see the back when you put the triple tray in. So we're going to use the coupling of the front teeth when we know the patient is in MIP as a proxy to know that they're in MIP. Again, this is without the triple tray. The next thing we're going to do is ask the patient to pick a spot in your mind's eye where your teeth come together. I want you to remember that spot and return to it when we take the impression. This is worth the price of admission for this free little seminar here. I learned this from a Dawson course years ago. Without a question, if we don't educate the patient on where to bite, they're just going to close. And there's all kinds of reciprocating muscle, neuromuscular activity that occurs when the patient bites into the highly viscous PVS material. So you can imagine when we're chewing, if our jaw senses that there's something there, the jaw actually has motivation to not go towards MIP because MIP is not the best in sizing and pulverizing masticatory function. In other words, our jaws don't line up when there's stuff between them. That's just built into our system. So if we don't really kind of coach our patient into MIP, there's just a high likelihood that they're not going to end up there. And if you don't tell them what to expect by having the conversation in the first step, they might end up wherever. And that's where the problems arise with triple trays. So we're going to try the tray in next. So first one, we had the patient bite down. We asked them to picture in their mind's eye where it is. You can change this verbiage to your liking. But then we're going to try the tray in for two reasons. And this first one would have helped this current case here to get a better sense as a provider or clinician of where to place it in the arch. And it's not always obvious. I can tell you that the clinician that did this does great work, and this particular triple tray didn't end up where it needed to be. I still do this today, and I think this algorithm, as I put it together, is more for me than anybody, but you guys are welcome to take it. My point here is that all of this sounds obvious, but I bet that some of it will upgrade, just using one or two of these items will upgrade your clinical outcomes over the long run. So the second reason to try in the triple tray prior to use, so with no PVS, is to get the patient used to biting with this thing in their mouth. Again, bites do not always end up in MIP. During this step, you then again ask them if they are hitting in the same spot as step number 2, or actually step number 1. The point is that we're having the patient repeat this exercise before it's game time. Practice makes perfect. So then, while the triple tray is in, again, no PVS, we're going to then again observe how the front teeth come together with an empty tray in place, confirming step number 1. So we're observing the relationship between the front teeth here to make sure that the patient, from a sagittal dimension, isn't biting forward, protruding forward, but they're coupling in the same way that they did when they're in MIP. Because at this point, we're starting not to see the posterior tooth relationship. So we don't know if they're biting down. We don't know if that gap exists between the back teeth like we saw in the triple tray. And then lastly, we place the tray with PVS into the arch and have the patient bite down moderately slow. There's different ways of doing this. I don't think that's really the exercise here. But I do find that if I insert the triple tray into the prep arch, I have better impressions. So in the lower, I will insert it towards the lower as the patient bites into place and they swing into the upper, versus an upper prep where I will place it into the upper and have the patient bite into place. All kinds of reasons why that works better. Suffice to say, that's really not the point of this exercise. I think we all do well here. But now we ask the patient, are they hitting in that same spot from number 2? Where they had picked in their mind's eye where their teeth come together. And honestly, most of the time, some of the time they say no. And then you just say, find that spot. There'll be patients that can't find the spot. They get performance anxiety and they can't. So what I'll tell them at that point is, don't worry about it. We'll let this set. The information from this bite is what we need. I'll take a simple bite after. And you can obviously just take a regular bite, send that to the lab, and tell them to remount it with that ancillary second bite. While they're biting down, with the triple tray and the PVS, take a look at the interior teeth and make sure they're coupling again, like in step 1. This is the confirmation step. So this is, I feel comfortable. So the patient might say, I'm there, but then I look in the front and I say, do the teeth come together in the same exact way they did when there was nothing in there, and I confirmed MIP. By the way, when you do that step, how do you confirm MIP? You put shim stock on the back teeth and you try to pull sideways. If it engages, you know you're in MIP. And you can use thin articulating paper, 10 to 20 micron paper, not that thick stuff we use for dentures, that's 80 microns. The point is there's ways to confirm that they're actually in MIP. Then you get to send to your lab with confidence that they won't need to guess where the occlusion is. Because if they have to guess, they have algorithms that they're going to undershoot this by a certain percentage to ensure that you don't have to send it back. The point is, that's not perfection. That's just a way to improve their bottom line. So that's pretty much it there. This algorithm is definitely a work in progress. I'd love to hear what people have to say. Please send your thoughts to me via email, and we'll add to this as we start to continue our journey in learning how to be a better clinician in the operatory through increasing our lens within the dental laboratory. All right, everybody have a good night. Thank you.